So to conclude, in our genome-wide association study, we identified a novel locus which is apparently associated with statin response, but it is the association is not true. It just reflects that these patients have higher LPA levels. So clinically, so if in clinic, if you see some patient who is not responding to statins as much as he or she should be, then it is better to check. I mean, it is I probably need further more studies, but you might want to check their LPA levels as well, because they might have a high LPA levels, and that's why they are not responding to statins. It is very much possible that physicians can just stop statins because of the non-response. Also, we replicated what was the known locus for statin response. So this data was just recently accepted, and these are online if you wanted to see them. And these are my acknowledgements.
Thank you very much for taking us through a very complex set of data, and congratulations on your work being published as well. We're doing well so far. Questions perhaps? I don't know if this is a relevant question because this isn't my area at all, but I know that a lot of people have quite a lot of side effects with statins, and I just wondered, is this relationship, is there a relationship between high LDL-C and, I mean, is the relationship between that and response, is there also a relationship, you think, between that and side effects profiles, or is that something that isn't part of what you're doing?
I think it's probably a very interesting thing to know, but I think when we talk about side effects, these studies are very important, because if you can also model side effects, like for example, some people have myalgia, so we can also model that, and if we know that certain individual has increased likelihood of having myalgia on statins, we might avoid statins. So I think that is one implication, that is one application of these kind of studies to side effects of statins.
I'm thinking that if you've got LPAs, like when you're less likely to respond, can you overcome that by just increasing the dose?
You don't. I'm not saying you are less likely to respond. I'm just saying that you see an apparent lower response, because when you measure LDL-C in the lab, you are also measuring LPA in that particle. So if you have a high LPA, then you see that the LDL reduction is small than what it actually is. So we are not saying that the response is it affects the response. We are just saying that it is an apparently low response. So, and to answer your question, I have not seen any data which say that if you increase the dose, you can reduce the LDL-C levels.
This is a good question. In terms of LPA and cardiovascular patients, do you know if there's a functional link? So, do they have more atherosclerotic lesion formation, or they are more susceptible to it?
I have not looked up in the biology of this, but there's definitely a much higher impact. In fact, 36% increased chance of developing CVD in those who have LPA. I have not even looked at what is the functional relevance of this SNP, but I know that it tags as copy number variation.
So those who have higher circulating levels of LPA are more at risk.
Yeah, and that's why you should not stop statins. There are the patients who actually should receive statins, and it's possible that because of this non-response, we might stop giving them statins.
Final question?
So if you treat a person with a statin who has a high LPA level, does that statin treatment also modify the LPA level?
No,
Or is that fixed level?
yeah, statins are known not to affect the LPA levels. If you want to reduce LPA, you can try niacin.
Thank you very much.